So on to Dr. Mahipal. He needs no introduction. Our immediate past president, chairman and medical director of the huge chain of CFS group of hospitals, and an amazing surgeon. And he is going to tell us how to choose the right IOL for your patient in 6 minutes, preferred practice guidelines.
Okay, good. So you didn't say an impatient Mahipal, right? Because when I went for my fellowship to Georgetown, the day my professor was giving me a farewell, he told my wife that I have never seen somebody as impatient as Mahipal. Because if he thinks of an idea today, he wants that it should be implemented yesterday.
Yeah.
So anyway, 6 minutes you said, right?
Yes.
Huh?
Yeah,
Okay.
you need to rise to the challenge
No,
besides being impatient.
I can't because there are more than... Anyway, basically I think maybe you people could ask the lenses, but it's a very difficult topic to...
We need not describe the lenses, your choices. What the audience should know. Which should they put for what?
AV team, please
I
check.
think there's something...
AV team, just please check.
How could you take the next question in Tariq while it's getting connected?
I think you can call the next person because this might...
It's not going. So can you
okay.
go out and again
No,
escape?
I have a
What do you think is the role of pre-operative atropine?
It works in not in all cases.
Yes.
It definitely works in some cases. And
In a floppy, in an IFS which you know pre-operatively, would you routinely give atropine to these patients pre-op? Any of you would like to start atropine for this patient?
I do give
Yes,
pre-operatively.
even I would give it,
yeah.
yes.
But some people say it doesn't work, some people, so
No,
at least from the satisfaction
don't
point of
mind.
view, we
Yeah,
give
you would
atropine.
have got
But that's
shot.
not the only thing we
No,
do. So there are,
thanks.
it's just one of the many things.
Yeah.
So
Yes.
No-
it's
no-
not
One
that
of the many
one of the
things.
many
Non-steroidal
things.
Nothing is the
anti-inflammatory,
only answer.
Atropine and non-steroidal anti-inflammatory.
Yes, yes. I do not believe that stopping the drugs for which act for IFS would help. But atropine and non-steroidal and all of these and keeping the eye soft, everything adds up besides the intra-op procedures. Do you have anything to add?
Dr. Chitra, the only thing is it's not just a question of whether it helps or not, but you can have a deleterious effect because you normally can give... yes, patient can go into an acute retention
Yes.
because you give atropine
Yes.
for cyclitis or something. Subsequently, the patient can go into a retention because
Yes.
you have stopped tamsulosin. So
Yes.
please do not stop
Stop
tamsulosin.
tamsulosin. That's very, very important. Yes.
Okay, can I start
Yes,
now?
yes, yes.
Okay, so you want me to only give the names or the choices or what do you want?
No, you do, you do.
Anyway,
Come.
the cataract surgery today has evolved from phakic glasses going on to good quality vision, going on to reading glasses and then freedom from glasses. That's what we are looking at. Premium IOLs have become more and more
Expert panel.
popular, and
you.
cataract surgery has today from a restorative surgery become a refractive surgery. That is something very, very important. And patients' expectation on perfect post-operative refractive outcomes, because we are able to deliver reasonably perfect outcomes, the patient expectations have gone. And this therefore induces a high demand on precise biometry, high performance IOL power calculation, surgery skills and post-operative results management, and the importance of counseling which is there. One important thing is I think this is something now standard. I don't know why the companies are still making the spherical, positive spherical lenses. They may be used only in some, but now the aspheric lenses, we still have to decide whether it is a zero aspheric or it's a negative this thing. So which one you want to use, but I think this is something very, very clear that an aspheric lens, a lens which does not compound the spherical abrasion which is there, is a standard of care today. I think that should be the standard of care which is there. So this is something aspheric IOLs, you can see in spherical IOLs you are having the less sharp vision, as you can see here, and you can see the sharp vision that you can have in the aspheric IOLs. Now next thing is what is I have totally, I would say, my practice has been cannibalized. All monofocal lenses have been cannibalized by this lens, which is an Eyhance lens. I think J&J has done a great job in hitting the sweet spot of a price. It is not something that you have to tell the patient that the price is much higher. Because it's only I think 2,000-3,000 rupees more than the MRP. So this is something which I feel is giving, has reduced the plus ad significantly. And there is a small bump in the center, that's about it. There is no dysphotopsia, there is no glare. So I think about 80 to 90% of my monofocal practice has been cannibalized. I don't even talk to the patient. There is no mismatch if the first eye has been done with a monofocal and you're putting a eye hands lens which is there. So this is basically good. Even if you have retinal problems, etc., you can do that. And this is fitting into the lifestyle of majority. The addition that you have, and if you do a little bit of monovision, the addition can go down to even a +1 or something. Otherwise, it's a plus 1.75 or 1.5 instead of 2.75. So this is a good lens for people who have big arms and things like that. And this is just called as a monofocal plus. So I would personally, if I have to do a normal lens in a person, obviously it is an aspheric lens. It has the blockers, and it is a lens which is giving a reduction in the amount of ad that is required in these particular cases. Now again, if there is any patient who has a toric requirement, you should ideally look at the posterior corneal curvature also, because you have to look at the total K. So that is something very, very important. And this is just to show you the K value. So I normally would use a toric lens in anybody who has an astigmatism more than 1 diopter. And because majority of my cases are today femtolaser assisted cataract surgery, which is say about 70-80% of my practice, I would do an LRI up to 1 diopter. So the lens of choice for me, anybody having an astigmatism, where I measure with the IOL Master 700, the posterior K, and therefore I go on for a toric. These are just ways to mark manually, and this is you could have a Varion system, or you could have the Callisto system which is there, and really not to show much. So this is the incision that comes on the Callisto, and this is the you have as to where the lens needs to be placed. That is something very, very important. And the last should be a slight nudge which is clockwise for you to place the lens. You can measure it subsequently as to how and where the lens is in the post-operative period. So that is, I think, toric lens, you have to ensure that you get onto a toric lens. If you are not onto a toric lens, there's no need for you to have a Callisto or a Varion, but you are a good surgeon. You can do a good in the bag placement. Please go ahead and do not refuse a toric IOL to a patient. I would say, I won't use a strong word like a criminal thing. It will be criminal not to give, but I think it will be a disservice to the patient if the patient has an astigmatism, which is a regular astigmatism, and you are not giving him or proposing him a toric lens. So that is my choice for a toric lens for these patients. Now presbyopia, obviously age more than 40, you have a problem which is monofocal IOLs will give you only distance, but you know, life is much more than distance viewing. So you have intermediate. Most of us are on smartphones. The average time that you spend maybe 1, 2, 3, 4, 5 hours on it, and then you have to do near work reading. Even though newspapers are getting obsolete, it's still on the Kindle and on the smartphones that you are doing that. But still, a lot of people need near work reading that has to be there. So multifocality, as I would say, there are 3 ways to go about it. You can do a monovision, you can do a multifocal IOL, and an accommodative IOL. A lot of people have invested a lot of money on creating accommodative IOLs, but I don't think that's the way life is going to go. Accommodative is something which is dead and buried. As of things today, none of these lenses have lived up to this thing. Now, when you are looking at the lenses, again, I would make a very strong statement that bifocal lenses are dead and buried. So there is no role today of the bifocal lenses. What you have to use is the trifocal lenses, and majority of the companies have come out with good trifocal lenses. It is very, very important that when you are doing a trifocal or a premium lens, that if there is an astigmatism that is there in those patients, that needs to be corrected, because the degradation of the vision because of residual refractive error in a trifocal lens or a premium multifocal lens would be much, much higher than it's in a monofocal lens. So that is something that you have to do, and you have to look at still, I would feel that the trifocality or the presbyopia correcting lenses have come of age only if there are no ifs and buts. That means कि भाई ये जो बात हम जो कर रहे हैं ना कि भाई patient क्या करता है क्या नहीं करता वो नहीं करता, that kind of situation should dissipate. That you can, like in eye hands, that is totally dissipated. I don't even discuss with the patient. I have done it for invasive cardiologists, I have done it for ophthalmologists, orthopedic surgeons, and they're pretty happy with that particular thing. So there is something that is, so still you have these problems which is there, but astigmatism that I have told is something very, very important. There are 2-3 things that a doctor should invest in. One is a good phaco machine. The second is a good biometer. because that is going to, and the third is a good microscope. So these are things which I feel are the things which you should invest, and maybe today also an OCT which is there. So biometry is something very, very good that you need. Dry eyes is something, corneal scarring, etc. Pupil which is not dilating, and unstable capsular support is something very, very important, because then if your lens decenters, there is a problem that you have. Glare halos to be told. I won't go into the detail, the angle, alpha, kappa, but there should be a centralization of the whole thing which is there. So newer IOLs which are there, the extended depth of focus lens, which was by the Symphony that came in, and then we have the Vivity today. I would again, it has gone out of my practice today, because if a person I have to give no glare, no dysphotopsia, I'll go for an IHENS. And if I have to give a person good reading ability and everything, I'll go for a trifocal lens. This Vivity or Symphony still requires the add on an IHENS maybe nearer to 2, and here the add in a Vivity or a Symphony maybe 1.5. So you're really not shaking the barrier significantly, and the charges should not be very high. And these are trifocal lenses which are there. My preferred, obviously, majority of the trifocal, when you're looking at a panoptics, it works at 40 centimeters, that's what it is. But you have actual reading should be at 33 centimeters. So the lenses, according to me, which are my preference today, which give you 33 reading, is the Zeiss 80 Lisa, where a lot of people think that there is a lot of PCO. We have just done a multicentric study. The results will be out. The incidence of PCO is not very high at all, and they are the most price sensitive lenses. So this is the tri which gives 50%, 30% and 20, which is there, gives you 3.33 addition. You're looking at 1.66, and you're looking at the distance vision that is there. I won't show you the video. And the CRV is a marriage between a trifocal and an EDOF. So that is a continuous range of vision, where you can have the lens going from near intermediate distance, and in between there is an EDOF which is there. So these are also results which are pretty encouraging that we are having. And this is the Synergy lens. The only problem with the Synergy is that we don't have a toric variety in this, so I can't work without a toric. So this is just the lens which is going in, which is there. So in a nutshell, it is our responsibility to match the right IOL to the right patient. Natural crystalline lens is a perfect multifocal lens, and basic purpose of a multifocal or trifocal lens is to restore accommodation in a pseudophakic patient and independence from glasses. So just to say that this is all that I have to say. Monofocal, my lens of choice, monofocal plus. IHENS is my lens of choice. Toric, you can go in for all the majority of the torics. Stability of the lens post-operatively is something very, very important, how stickable it is. And in the lens for giving you for a presbyopic correction, I'll go in for a trifocal lens, but the toric element has to be corrected. And there are, I think, 3 Indian companies also make good trifocals. You have the CRV, you have the Zeiss trifocal, you have the Panoptics, and you have the Indian companies or whatever they, I don't use much of them, but that is what it is. So I think that is what I have to say, and thank you very much for your kind attention.